What I'm here to talk to you about today is Cardiac Solutions. Cardiac Solutions is a program that I put together for Centrex Rehab, and with all our solutions programs, what we're trying to do is heighten the quality of therapy services with certain types of patient populations and diagnoses. So in this case, it's going to be about the cardiac patient, be it post-operative or just a medical diagnosis like an MI or CHF, congestive heart failure, or a heart attack. Okay, so moving along, why was Cardiac Solutions even needed? Well, there's a couple of big reasons. One, like I was just saying before, with our solutions program, we're trying to create excellence in our therapy programs. So Cardiac Solutions is an example of that. The other reason is it's something our partners want. Ebenezer is our partner. Fairview is our partner. And especially in this day and age with how healthcare reform has impacted the United States, you're having providers of healthcare come together. So the hospital, the skilled nursing facility, an outpatient center, we're all coming together at the same table, and we're the therapy providers at the table with you. So we want to succeed by helping you succeed. One of the things when I looked at Cardiac Solutions was I needed to recognize, what do our partners need? What do you guys need in order to help you be successful? So first of all, about 2-3 weeks ago, I was here at a training session with some of the nurses from Fairview. And one of the things they pointed out from an acute care viewpoint was rehab centers that do not have patient move for 3 hours means they do not refer to that TCU anymore, right? Do any of you remember hearing that a few weeks ago? Well, I was here and it was definitely said. So obviously therapy is going to be a big part of that, as are you guys, to make sure that the patient is moving and not sitting around for 3 hours. We want to support the patient education process. Now, one of the things that's important about this is everybody has responsibilities about what they educate about. So therapy isn't looking to take over what nursing per se is educating about or what the doctor's educating about, but what we do want to do is support the great education that you guys give the patients. So things like risk factors, and one of the things we know is the more a message is repeated, the more the person tends to hear it in the end, and hopefully will buy into that and make the behavioral changes that a cardiac patient needs to make. We also will be monitoring the patients in order to provide a safe and effective exercise and functional task prescription. So when I say exercise and functional task prescription, having that word prescription might be a little new for you to hear, because I'm sure you're used to prescription in terms of meds. But in the therapy world, we also think in terms of exercise prescription. By that I mean, I need a baseline of that patient in terms of their vital signs, their blood pressure, their pulse oximetry, their respiratory rate, because I have to know, a target heart rate also, because I have to know where are they at baseline and what am I doing with them as a therapist? Am I keeping them in a safety zone? Am I progressing them in a safe way? Or am I entering an area that's dangerous to them? So that's what I mean by exercise and functional task prescription. And that's why you'll see our therapists constantly taking vital signs and that sort of thing. Also, what our partners are looking for is monitoring the patients in order to provide a safe and effective, well, that's a repeat, but what I just spoke about, the exercise and functional task prescription. We want to support, obviously, a safe transition home, support transition to outpatient cardiac rehab. That's a biggie. We know that cardiac patients who go on to participate in outpatient cardiac rehab have an improved longevity rate as opposed to those that do not. And of course, IDT, interdisciplinary team communication. We very much want to be a part of that here, and we are a part of that here. And then Just a question that I want to put out to you guys is that if there's anything else that you could think of as a partner that you think therapy can offer. And it's okay, you don't necessarily have to raise your hand now and say it, but at the end, I have my email address, and of course you have Megan Van Oort, the RD here, so you could just go directly to Megan, and we'll always make sure that we're partnering in the best way possible. So Cardiac Solutions is largely based on the American Association of Cardiovascular and Pulmonary Rehabilitation. That's the association for cardiac rehab in the United States. And they put together this proposed model for post-acute cardiac care. And then also there was an article called Cardiac Rehabilitation in Skilled Nursing Facilities, a Missed Opportunity. And when I found that article, that was like gold to me because that's exactly what I was working on. So what you're looking at here is the model that the association proposed for post-acute care. On the, let's see, stage right, okay, stage right, the blue vertical line, that's what's taking place in the acute care in the hospital. So that's inpatient cardiac rehab. Once they get out of inpatient cardiac rehab, they're coming into the post-acute care environment. So that's where you're seeing up here, it says the skilled nursing facility. And when they come into the skilled nursing facility, there are going to be things that nurses and therapists and social workers are all going to be interested in knowing about the patient. So the illness severity, something that comes to my mind immediately is what's the ejection fraction of that cardiac patient? Because that's going to correlate to how hard I could work them. Cognitive status. Our occupational therapists like Megan, they'll do cognitive screens. Why is cognitive screen so important? Well, for me as a therapist, Megan can tell me, Matt, this is where this person is functioning at cognitively, so here's the best way for you as a physical therapist to work with this patient so that they'll get the message and they'll learn in the best way. Physical function, obviously therapists do evaluate physical function, be it activities of daily living, walking, going up and down stairs, what have you, everything that's important for that safe transition home. Depression. Now, we're not doing the screening for depression. My understanding is typically that's social work, but as a therapist, I sure want to know if this person is experiencing depression because depression has negative impact on the outcomes for therapists, as I'm sure it would for nurses and doctors alike. So it's important that we're aware if this person has depression. Pain, obviously we want to know about pain, and as therapists we're going to do what we could do to alleviate pain so the function is better. Obviously as nurses and as doctors, you're going to do the same exact thing. Complications and comorbidities of the patient all impact how that person functions, and we have to, as therapists, consider that. And then what's the social support of the patient? So when they leave the TCU and go home, who's making sure they're doing that home exercise program, or who's making sure they're transitioning and functioning at home safely until that nurse and therapist gets into the home to carry them to that next level of care. With skilled nursing cardiac care, what the association proposed is that under exercise, we need to risk stratify. So what we do as therapists is we know based on certain criteria, is this person considered high risk, medium, or low risk for exercise? For instance, that tells me, can I have this person do this type of activity which requires this much energy? Well, guess what? If the ejection fraction, if the amount of volume of blood that their heart puts out doesn't allow for that level of activity, I'm not going to do that with them. But what I'm going to do is step by step help them to get stronger or learn energy conservation techniques so that they can do that sort of activity. We're going to, as I mentioned before, we're doing a whole lot of monitoring of the cardiac response to exercise and function. We're looking at endurance training for that patient. Under education, we're looking at symptom management and survival skills. and the importance of phase 2 cardiac rehabilitation. So again, this is all part of that proposed model, but these are all the things that I know we as therapists, and I'm sure you as nurses and physicians, are looking at the same thing. Then in the model, you're looking at the number one choices to make sure that person goes home. Of course, we know not everybody always goes home, so sometimes somebody winds up in long-term care, and the least desirable is rehospitalization. And I know we're going to all watch these patients like the Dickens so that we never see any rehospitalizations, hopefully, right? And this is really the previous slide, and it's just pointing out the things that the therapist will look at in the initial evaluation. The arrow, the next to the last arrow, body structure impairments, what that refers to, just so you understand the lingo, is let's say there's a joint like a shoulder or a hip, and there's some sort of impairment to it, whether someone fractured or there's tight tissues, that refers to body structure impairments. So if Megan, as an occupational therapist, can see that the shoulder is tight, but that patient needs to be able to reach a shelf, well, if they're a cardiac patient, they may have sternal precautions, so maybe it's a shelf out here, but they don't have the range of movement to reach out there. That's something that the occupational therapist will work on with the patient in order to do so that they can transition home. Again, all the things we're looking at, depression, pain, complications, comorbidities. Comorbidities, if you don't know, refers to all the other medical conditions that a patient might have, and it impacts their health. So when it comes to exercise, before I mention risk stratification, we look at a high, medium, or low risk stratification. We monitor and we document in our electronic medical records what the cardiac response to exercise and activities are. So we're looking at things like vital signs, vital signs, something called the Omni-Perceived Exertion Scale, which I'm going to show you in a bit. And of course, we're looking at endurance training. And when it comes to endurance training, payers like Medicare don't want to just know you're working on endurance, but they want to understand how it connects to function. So in our documentation, we also connect, we're working on endurance, and what does that connect in terms of function, so that they can access all areas of the TCU, so that they can access all areas of their home environment. When it comes to measuring on an ongoing basis, we're doing it when we first see the patient. So Mrs. Jones, I'm your physical therapist, I'm your occupational therapist, and I'd like to take your blood pressure and see your oxygen levels. We're doing it in the very beginning, we're doing it during the treatment, and we're doing it at the end of treatment. We're looking at the pulse rate, and I have heart rate up there, but of course that's an EKG sign that gets measured. We're looking at the blood pressure, respiratory rate, SpO2, or also known as oxygen saturation levels, and pain. And then up top in the corner, you might be familiar with the FACES pain scale. So that's just one type of pain scale that we might use when we're measuring pain. We're also looking at what is the target heart rate. So that means how many times can that heart beat? How many times can that pulse beat in a minute and still keep that patient safe? It's our hope that when the patient comes over from acute care, that information will be in the medical chart. If not, our therapists know exactly how to calculate it, but what they're going to want to do is then communicate, again, interdisciplinary team communication, with the nurse practitioner, the physician, and say, hey, this is the target heart rate that we've calculated based on this formula. Are we all on board that we could work this patient up to this maximum heart rate, yes or no? We're going to consider the impact of medications. For instance, a big common cardiac med is beta blockers, which blunts or maintains that heart rate. So you can't, the patient isn't going to say, God, my heart is pounding more and more and getting more rapid when we're doing activities with them. We need other ways to monitor that. And one of those ways you'll see in the bottom left corner is that Omni scale, and I have a blow up of that, and I'll show you exactly what that is. But it's called the the rate of perceived exertion, knowing how hard is that patient working, that person working. So here you're looking at the omni-perceived exertion scale. What it does is in the yellow zone, you have the numbers starting at 0, where they're not tired at all the way up to 3.5. Starting at 4, they're getting more tired, 6 is tired, 8 is really tired, and 10 is very, very tired. So practically, how does this work, and how might you even employ it as a nurse? Well, if I go and work with a patient, and I'm going to do something called a 2-minute walk test, okay, how far they could walk in 2 minutes. I'll say to my patient, we'll call her Mrs. Jones, Mrs. Jones, if you look at this paper, where 0 means not tired at all and 10 is very, very tired, where are you right now? Okay? And Mrs. Jones says, I'm about a 1. Great. Then we stand Mrs. Jones up to do the 2-minute walk test. Assuming she's able to walk 2 minutes, we're asking Mrs. Jones, where are you on this scale now? And Mrs. Jones tells me she's a 9. So that might be a baseline test for a 2-minute walk test. My goal is to see, can I get her by the time she leaves the TCU at a lower number, maybe in the green zone, or maybe even in the yellow zone. So that's how you might use the Omni scale. So as nursing staff, maybe there are activities you do with people also that you might find something like this helpful. And Megan has a whole bunch of these in case you want to get copies, and so does Amy. I shared it with Amy as well. Also, by being partners with you in Fairview, I know that you're probably familiar with all this by now, but how I manage heart failure. Our therapists also have this form. So we're going to reinforce the great work that you're doing and the great work that started at Fairview, and we're going to talk the same language all across the spectrum of care. That's really important. And again, reinforcing the message with the patient. Then Fairview has their stoplight tool for those recovering from heart surgery. Again, it's the idea of reinforcing using that same tool. Our therapists will have this same tool available to ask those same questions, show those same words. So, outcome measures. I mentioned a little bit before, we do this thing called a 2-minute walk test. For physical therapists, there are probably going to be 3 big outcome measures that they'll look at with a cardiac patient. The first 2, they'll do one or the other, depending upon the patient's abilities. The 2-minute walk test, and it's just seeing how far, what distance that patient can walk in 2 feet. The 6-minute walk test is the same thing. It's what distance can they walk in 6 minutes. Through meetings that took place over the last several months, I met with the director of rehab and the cardiac rehab people from Fairview, and I happen to know that they use the 2-minute walk test. One of the things that they said to me would be great is that when we see cardiac patients here, if we could supply them with the information from, let's say, the 2-minute walk test and what their Omni perceived exertion numbers were, that would be great. And that's exactly what we want in healthcare. We want to know, what did they do in the hospital? What did they do in the TCU? What do they do in outpatient therapy and cardiac rehab? Because then we're all talking the same language and we're demonstrating the progress of that patient. And we're not starting over at each transition of care. And then finally, a physical therapist would look at a 30-second chair rise. So here's what a 30-second chair rise is. Because you have wheels on your chair, I'm not going to ask you to do this. But you would basically just sit in your chair with your arms folded, and it's the ability to stand up out of a chair for however many repetitions, up and down all the way in 30 seconds. And there's been research on this test. It demonstrates how strong the legs are, but we know normative data for age-related normative data and gender-related normative data. So if your patient is a 75-year-old male, we know they should be able to do this many repetitions. Or a 65-year-old female, they should be able to do this many repetitions. In reality, maybe they'll leave here doing 1 or 2 repetitions. That's okay. As they go along the continuum of care, they'll get stronger and stronger, right? But they'll know, what did they do at the TCU level? For occupational therapy, as I mentioned before, they're going to do cognitive screens and assessments. And don't worry about the located in policy manager part. That's a Centrex lingo. But they'll look at the slums or the MOCA or the CPT. And Megan, had you had a chance to talk about that? So I'm not going to repeat that, but obviously cognitive screening is important. Barriers and impacts. So our therapists also have this form called the Readiness to Change Survey. The Readiness to Change Survey is something you might see more in the physical training world, but it's a few questions that you ask a client or a patient, and based on how they answer, you then know how ready are they to make behavioral changes. Like, is this person really ready to change by starting an exercise program or not? And it gives you a clue as to where you need to come from, what psychological standpoint, what educational standpoint you need to come or approach that patient from. We want to know what kind of medications they're on. Our therapists have this handout of all kinds of medications and what the cardiac input is on that patient. Our therapists have handouts on the different cardiac surgeries. So for instance, CABG or coronary artery bypass graft and valve replacements, which are two of the more common. They have information on intervention strategies and guidelines. Remember the risk stratification, high, medium, and low. The metabolic equivalents. So metabolic equivalents or MET levels, they have this handout saying this type of activity equals this MET level. And for cardiac patients, there are known MET or energy levels that that person should exert based on what risk level they're at. So the therapists have that information. They also have information about absolute and relative contraindications to exercise training. So there are national guidelines, and they'll know when they need to say, you know what, something's not right here. We need to stop at this point. We'll only bring you up to this point. Or you know what, you're at this lowest level and I don't feel comfortable about exercising. So what are we going to do as therapists? We're going to come to nursing and the nurse practitioner and discuss that and have a little IDT communication about it. Other interventions, well, obviously our goal is for improving physical function. We're going to have educational goals. As I mentioned before, research demonstrates that repeating the message to the patient helps them get through. Like, how many of us here know the patient who've been told umpteen million times, smoking really is not good for your health. It's not good for your heart, not good for your lungs. And sometimes I know I've been like this. I'm like, oh, am I going to really tell this person again? Say this message that he knows? Well, it turns out, yes, I'm going to do it, because the more we repeat it, eventually you're going to be that person that makes them get the message or helps them to get the message. So with our education, we're going to support what physicians and nursing is responsible for. We're going to educate on the benefits of the active lifestyle. We're going to educate on energy compensation techniques. If you're not familiar with that, what that means, that's something that occupational therapy will address, and it teaches the person how to do an activity but require less energy output on their part. And we're going to support transition to outpatient cardiac rehab. Another thing I want to mention is that you're hearing me talk a lot about physical therapy and occupational therapy. It turns out that we don't think a lot of the cardiac patients we get will necessarily require speech-language pathology, but some of them might. Some of them may come from a procedure where there are swallowing issues, for instance, and we will have speech therapy present to evaluate and treat if necessary. This is just a slide letting you know that Centrex utilizes a online education website, MedBridge, specifically for therapists, and we have all kinds of wonderful online education. So this is just an example of a couple of courses that we could take, and we also sponsor continuing education. As a matter of fact, I think in March we have a professor coming from the University of Minnesota to do a cardiopulmonary course. And these are just references that went into our creation of Cardiac Solutions. And with that, I will say, does anyone have any questions? Another thing that you'll probably see happening, especially with the cardiac patients, is they may be going through what we call split visits, where a patient comes in and they can't tolerate, let's say, a full hour of therapy at once, but maybe they could tolerate 20 to 30 minutes. So the therapist will end up seeing them that 20 to 30 minutes in the morning, 20, 30 minutes in the afternoon. Now, while at the TCU, if that patient gets stronger and can safely tolerate more time, we're fine. I mean, that's great. Build up the time, and maybe that person towards the end has one session as opposed to 2 sessions, but that'll all be based on medical necessity of that particular patient. I was asking about scheduling for therapy times, and Megan Van Oort, who is our rehab director here, was just saying that they would be addressing that offline, but some of the important concerns for nursing was making sure that the patient has whatever medications they may need and have sufficient time for those medications to take effect so that therapy could then come in and get the best bang for the buck, so to speak, have great therapy outcomes as a result. How will nursing assistants, right, and nursing know how many people are required to do a transfer with a patient? 1 person, 2 person, do we need equipment? And that'll happen through a nursing communication form that therapy generates to nursing. And that way you'll know, is this person 1 person, 2 people assist? Is it a Hoyer? Is it an easy stand, or what have you? And the other thing is, if ever there's particular nuances about the transfer, therapy will certainly work with nursing on making sure you're trained and independent in doing that transfer. One thing, when they come in from the hospital, we have medical records, so we would know what they did with therapy in the hospital. But the day they get here, therapy is also evaluating them, so they will know what they require that day. The other thing, this is a really great question, is even though they might come across the Skyway, especially with older adults, when there's a change in environment, sometimes we see the function decline. So even though they were doing one thing in the hospital, maybe they won't do as well here, just simply because they're in a new environment, and that brings up certain anxiety. So that may happen sometimes, or it may not. For instance, if a patient goes to the dining room because the nurses are encouraged to make sure that the patients get back into their normal life activities. So you walk to your meals, but how do we know if they might need some supervision or assistance? Do I have that question correct? Great. And I think, yeah, and what their safety level is, which to me means the level of assist, because do I need to be right next to them? Do I need to hold on to them? Or are they independent doing that? That'll be handled the same exact way that transfers are handled, and through a nursing communication form, the therapist will make sure that that information is clear. Well, thank you very much. I appreciate it. I'm probably the last act of the day, so I saw your eyes stayed open. That's good.